We start our National Symposium on Diabetic Retinopathy. So we have a galaxy of speakers, and I first of all invite Dr. Muna Bhende to give a talk on evidence in medical management of DME.
Good morning, everyone, and thank you for those who managed to find their way down to the second basement on a Sunday morning. And thank you, Piyush, for inviting me for this meeting. I'll be just spending a few minutes talking on the evidence in medical management of diabetic macular edema. I think this is something none of us disagrees on. It's important to know the patient. And we know that optimum treatment benefit happens only if there's good glycemic control and treatment of other comorbidities, helped by appropriate investigations, and then treatment. I think something for which we now have evidence is differentiating between center and non-center involving DME, where the crucial point is the central subfield zone of 1 millimeter in diameter. And this is what drives all our treatment protocols. So once you have a patient with diabetic macular edema, if it's non-center involving DME, then we tend to go to the good old EDTRS criteria for laser photocoagulation. And this has been shown to have a relatively stable visual acuity, good retinal thickness, and decreased fluorescein leakage area at 1 year. However, when it comes to center involving DME, there are two possibilities. You can have it with visual loss and no visual loss. Now, if we have patients with center involving DME and good vision, then the findings from protocol V are important, where on the surface we saw that there was not much difference whether you observed, you treated with laser or treated with aflibercept. But if you look closely at the results, you find that the best results in terms of achieving 20/20 vision, a stable retina, was with aflibercept. How do you apply it in real life? If you have a compliant patient with regular visits, you can always observe. If they need better vision like an airline pilot, then you would need to treat. And if there's poor compliance for follow-up, as we all know, laser is the option. Now coming to center involving DME with visual loss, protocol I showed us that ranibizumab had better outcomes than laser, but laser could possibly reduce the number of injections in eyes with better visual acuity. There is the risk of glaucoma with intravitreal triamcinolone alone. We know that after the year 1, majority of treatment can be weaned off or reduced. There's a temporary improvement in the DRSS scale. And probably ranibizumab does not have as much systemic risk, but we know all these trials have a strict inclusion criteria. Now, how do you compare the anti-VEGF agents? And we got this evidence from protocol T, where all 3 anti-VEGF agents have improved visual acuity. If the vision was good, there was no significant difference between the 3, but the better anatomical outcomes were seen with aflibercept and ranibizumab. If the vision was poorer, aflibercept was better at year 1, but equal to ranibizumab at year 2. Bevacizumab was definitely inferior. Now, when we look at how to define response, everyone says more than 15-letter gain, more than this much thickness, but we know it's not possible with all levels of visual acuity. And this exploratory analysis gave different thresholds for good and poor response depending on the visual acuity and the macular thickness, which was very easy to interpret. How do you apply this in the clinic? At the end of 2 years, the strong response to patients in terms of visual acuity and central retinal thickness, that response is maintained only in about 69% of patients. A lot of them, if there is only one category you're looking at, either visual acuity or CST response, there's a 50% chance of strong response after 6 months, and 75% of strong responders maintain at 2 years. And there is also a possibility of delayed response. Now coming to steroids versus anti-VEGF, there have been about 14 studies, and this was a meta-analysis. Anatomical response is good, but no specific visual benefit. You have to look at the potential side effects like glaucoma, cataract, and endophthalmitis. Most of the studies used bevacizumab, and most of them had triamcinolone. Now, protocol U combined steroid with anti-VEGF versus anti-VEGF alone. The visual gain was comparable, but the structural outcomes were better. Now, this is the open label extension and endurance trials in DME, which were the 4 and 5 year extension studies. And they showed that around 4th and 5th year, you could go to an individualized dosing schedule based on the central macular thickness. It's good to know that a quarter of patients did not require additional anti-VEGF treatment beyond year 3, but they did occasionally require it, indicating that the disease process doesn't go away totally. What is more important, there is documented worsening of diabetic retinopathy once you're off the anti-VEGF injections, which is something that is significant. We have various treatment protocols, monthly PRN and then monthly followed by fixed, treat and extend, PRN and personalized treatment interval. I don't have time for all of them, but usually one would go to individualized treatment. Now coming to brolucizumab, these were drugs that were intended to have better results with a longer duration of action. There were 2 studies, the Kestrel and the Kite. And if we look at it, they were non-inferior to aflibercept at the end of 2 years. The Kestrel study showed non-inferiority, but if you look at the Kestrel study showed slightly better response with aflibercept 2 milligrams. And again, there was a certain proportion of patients with central foveal thickness less than 280, and probably the best results were with brolucizumab. However, and this is quote from the article, the risk of intraocular inflammation is significant and cannot be ignored. So again, the dual anti-VEGF agent, faricimab, in the Yosemite and Rhine studies compared faricimab 6 milligrams every 8 weeks following initial treatment with 6 monthly doses, followed by a personalized treatment interval against aflibercept at fixed 8-week intervals. And this had non-inferior gains. But if you look at the patients where there was absence of DME at the end of 2 years, the highest was in patients with faricimab every 8 weeks. And it was possible in a significant number of patients to extend the treatment interval to every 12 weeks or 16 weeks. And most of these studies, except probably the brolucizumab and the faricimab studies, have been utilized in the consensus statement from AIOS and BRSI, and they more or less follow the similar guidelines that are seen in the evidence that I have presented earlier, where they have the guidelines switching to intravitreal steroids as well, and also a role for laser photocoagulation. And subsequently, there's another publication from the Asian group, which again says that anti-VEGF is preferably the first line of treatment, dexamethasone in certain selected cases with high risk factors, and other treatments like laser and surgery depending on the biomarkers. Now, consensus is something, guidelines and something, evidence is something else. And there are 2 studies which tell us that consensus does not always agree with guidelines or evidence. And the study also showed that the definition of DME, the need for stable metabolic parameters, and the use of a second anti-VEGF when to start it was always controversial. And this was also seen clinicians versus AI in the study from Narayan Netralaya, which showed that when treating center-involved DME with good visual acuity, presence of coexisting lattice degeneration, renal disease and anemia, and a recent history of cardiovascular disease, there were clear disagreements. So to conclude, to manage your patient, it's important to know the patient first. Definitely systemic control is important with appropriate investigations. Proceed with treating as per available evidence and appropriate guidelines. Thank you very much for being here today, and I welcome you all to Chennai in July for our Retina Summit. Thank you.
Thanks, Mona. Scheduled a flight to take early in the soon after. Do we have any question from the audience? Okay, if not, can I invite Dr. Vivek Dave to talk on surgical implication of VR interface in diabetic retinopathy, a case-based study.
I think, good morning, there was a change of topic Thank you, Piyush, for inviting me. I'll be speaking to all on implications of vitreoretinal interface in the management of diabetic retinopathy. So as we see, diabetic retinopathy and maculopathy come in various shapes and sizes, and a lot of times have surgical implications which vary from case to case. A central pathology to these conditions is the vitreoretinal interface, and you can have different clinical presentations, each with their own surgical implication. It could be PVD with vitreous hemorrhage. It could be absence of complete PVD, hence presentation as a subhyaloid hemorrhage, a thickened premacular hyaloid, vitreomacular traction, something called as progressive preretinal fibrosis, and various combinations of epiretinal membranes, pseudomembranes, true holes, and something that we call as double membranes. So we will go through a few of case examples demonstrating these pathologies in the slides ahead. So if we are having a good day at the office, we might face something which is a plain vitreous hemorrhage. In general, in diabetic vitreous hemorrhage, this is not a very common surgical presentation because here largely the PVD is present. So this surgery is simple, without any significant membranes, could be pure vitreous or may have a mild subhyaloid component, could be fresh or could be old. So surgery in general, as seen on the screen, goes largely uneventfully. We can go ahead, clear out the vitreous hemorrhage, laser the retina, and the patient does well. More often than not, this is what we see. The posterior hyaloid is detached partially. So you may have what is classically a peripheral posterior vitreous detachment, but on the posterior pole, because of severe adhesions at the equator and posterior, the hyaloid is held back. So any bleeding that occurs is held back below the hyaloid, and you have the classic subhyaloid premacular hemorrhage. But because there is the hyaloid and the retina and blood in between, you have working space between the retina and the hyaloid, and hence it can be entered with a cutter. The disc attachments can then be managed with forceps. So we will see this case example. I'm going ahead and doing an anterior and core vitrectomy. And because there is space, the space allows me to confidently insert the cutter. And as you can see, the hyaloid is being cut and gently being elevated from over the retina. Now, whatever is the accumulated subhyaloid hemorrhage, I'm using a back flush to dislodge it, and then using a forceps elevating the posterior hyaloid. And while you're elevating, it's very important to keep looking at the retina. If you feel that the retina is getting tented up, that means the adhesion is very strong. That is where you need to stop and then cut around that elevation so that you do not create a break. So once that is done, again, go ahead, laser, and largely things stay fine, like what is seen in this post-operative photograph. Now, there is something called as a thickened premacular hyaloid, where the retina, quote-unquote, doesn't look very hot, but you have this fibrosis over the macula and classically some space between the retina and the thickened hyaloid. So you can see this fundus photograph and the corresponding OCT, where you will see the thickened posterior hyaloid, but a lot of space between the hyaloid and the retina, telling you that you can insinuate an instrument in between and then sort of cut across. But often the hyaloid is so thick that it will not conform to your cutter, as we will see in this video. After doing a vitrectomy, when I attempt to take my cutter, the cutter really doesn't puncture. So what I like to do is take in a needle, and from the edge of the needle create an opening in the posterior hyaloid, and once that opening is made, then the cutter can be insinuated along, and your OCT, which we saw previously, acts as a guide to tell you which are the areas where there is a space so that you can enter confidently. And once you get that plane, usually these cases also do not have too much of a hemorrhage on table, and the hyaloid can be removed successfully. So this is the post-operative photograph of this patient 1 month down the line. This is a term which I was not very familiar with in the initial years of my career, but I realized this is something that has been mentioned in literature called as progressive fibrovascular proliferation. So this is a type of severe PDR which comes to you. You see the patient in time before it becomes a surgical retina case, and you do a good laser. But what you end up with is a quiet eye, very well lasered, but the entire hyaloid which is fibrotic. So this has been termed as a progressive fibrovascular proliferation. This paper that I alluded to very nicely describes what happens, why it happens, and how you go about managing it. So this was a case of progressive fibrovascular proliferation. We could see that the retina otherwise looked attached, but perifoveal retina had lifted off, and the patient was symptomatic with visual distortion and drop of vision. Surgery in these situations is not difficult from a hemorrhage point of view, but the key here would be to ensure wherever you are removing the hyaloid, you do not end up tenting or pulling the retina much, and hence do not cause a break. So here I am insinuating the cutter again in the plane that is very nicely visible between the retina and the hyaloid. While I was managing this, largely things went fine, but somewhere I think I did get a break, and we had to put in tamponade. Now, gas would have sufficed, but the patient coming from a different state, having to fly off, we had to use oil. But as you can see, all the elevated perifoveal retina very nicely flattened back. Vitroschisis and double membranes is something which is a part and parcel of a diabetic surgery, always important to keep it in mind. In fact, for me, the last step of any diabetic surgery is to inject Kinacort and see that it very freely does come off passively in the flute needle or the green tip, thus confirming that there is no gel layer left behind in which the crystals of the Kinacort are entangled. This is one example of vitroschisis and double membrane, a diabetic surgery where after a core vitrectomy and reaching the posterior hyaloid, I could see that the hyaloid was fibrotic, which very well came off. But then IOCT showed some amount of traction which still persisted temporal to the retina and had a localized retinal detachment. And as I kept dissecting that area, I realized while I removed something which looked like a posterior hyaloid, there was another complete thick membrane covering the macula and the temporal retina below it. So this was an example of a double membrane where in spite of something coming off clearly, I had another layer behind. Then again I injected Tricort just to find there was a third layer, thinner but a complete layer below what seemed to be the second membrane. So multiple layers coming off, and you can be confident that you have removed them all by finally staining your retina with Kinacort. Vitromacular traction is again something which can present idiopathically as an isolated pathology, or it could be a part of PDR. As per literature, 14% of surgical indications in PDR are associated with vitromacular traction. This was one such case, well lasered PDR, some amount of asteroid hyalosis and vitromacular traction with macular edema and a symptomatic patient. Also had cataract, which I removed, and then went ahead, did an anterior and a core vitrectomy. IOCT, if you have, well, it can show you a plane, otherwise you can go by your pre-op OCT. Here again, what I'm doing is insinuating my cutter between the disc and the foveal attachment in the area where the posterior hyaloid is detached. I like to do something which, for a want of a better term, I call foveal isolation. That means just cut off the entire posterior hyaloid which is attached to the fovea around it, so that the fovea and the minimum attachment of the hyaloid on the fovea is separated from rest of the posterior hyaloid. So that way, once you have separated the fovea off, you can go ahead and induce your PVD in a classic fashion. Then again, because it's a diabetic patient where PRP laser has been done, always keep a good look at the rising edge of the posterior hyaloid to be sure that it is not pulling on any retinal scar and you don't end up creating a break. So once the fovea is isolated and the posterior hyaloid is removed, these cases otherwise do well. And this is the post-op of the same patient. So in conclusion, the pathoanatomy of the vitreoretinal interface is the main determinant of the surgical approach in a diabetic eye surgery. Recognizing this helps the surgeon plan the surgery appropriately to get the optimum surgical success. Thank you so much for your attention.
Thank you so much, Dr. Vivek. So you've taken us through all the scenarios of VR interface in diabetic retinopathy, and congratulations on this wonderful bouquet of cases that you showed us.
Thanks, man.
So
Thank
with
you.
this, we move on to the original order now, and may I invite Professor of Ophthalmology at RPC, Dr. Praveen Vashisht, for his talk on epidemiology and role of AI in diabetic retinopathy.
Thank you, sir. I'll be talking about epidemiology of diabetic retinopathy, specifically in India, and some role of AI. In fact, as far as diabetes is concerned, if we see currently, as per the International Diabetic Federation, the prevalence of diabetes is 10.5% globally. This amounts to nearly 537 million diabetics. But unfortunately, nearly 44.7% of them remain undiagnosed. And an equal number, 10.6% for 541 million, they are pre-diabetics. So what we understand is, as per the estimates, by the year 2045, the number of diabetic will increase to 783 million. If we consider a similar scenario for India, the prevalence of diabetes in India is slightly higher. It is 11.7%. This is as per ICMR India app study, amounting to 101 million diabetics. And beside this, the number of pre-diabetics is still higher. It is 15.3%, amounting to 136 million. This was published in 2023. And as far as diabetic retinopathy is concerned, this is based on a meta-analysis, a systematic review published in 2020. The prevalence of diabetic retinopathy is 22.27% globally, amounting to 103 million diabetic retinopathy cases globally. And beside this, the vision-threatening DR is 6.17%, amounting to 28 million people, and clinically significant macular edema is 4.07%, which is 18.83 million. By 2045, it is expected to increase to 160 million diabetic retinopathy cases globally. In India, in fact, we did study National Diabetic Retinopathy Survey as part of Government of India survey conducted by RP Center. As per this survey, prevalence of diabetes in 50+ age group, in fact, we took a cutoff of more than 200 milligram per deciliter as per RAB survey strategy. The prevalence was 11.8%, and among them, nearly 1/3 were new cases, newly diagnosed cases. The prevalence of non-diabetes was 8%, and new diabetes was 3.8%. Another unfortunate part is nearly 60% of the diabetics, they have uncontrolled diabetes among the known cases. That means their blood sugar was more than 200 milligram per deciliter. Then prevalence of diabetic retinopathy, we got 16.9%. This was almost similar in male and females. And of course, in 50 to 59 age group, the prevalence was less, but in higher age group, it was nearly equal. And probably the most important finding we got, that in spite of the retina expert in country, 90% of the diabetic patient in India, they are never examined for fundus examination. 90%, there's hardly 10%, and among those 10%, 6.3% are actually examined in last 1 year. This is the prevalence of diabetes and diabetic retinopathy. We can easily see all over the country. It is more in Kerala, more in Tamil Nadu, more in Goa, and more in Punjab. In fact, this represents all those states which has high epidemiological transition level. That means we need to give more importance to these states in the country. But when we see diabetic retinopathy, whether it is responsible for blindness or visual impairment in country, and what we can observe that it is not an important cause of blindness and visual impairment. Just because only cataract and refractive error are the leading cause of blindness and visual impairment, DR is just 1.2% of blindness and only 0.7% of MSVI in the country. We have compared with other studies also, and in our study the prevalence was 16.9%. As per Smart India study, which was done in 40+ age group, it was 12.5%. Prevalence of STDR in our study is 3.6%. As per SMART study, it is 4%. That represent that in a population of 100 million diabetics in India, nearly 4 million they have vision-threatening diabetic retinopathy. And this is another meta-analysis which has been done by TP sir and team that involved all the major studies on diabetic retinopathy in India with risk factors and everything. As per this meta-analysis, the average was 16.1%, so almost close to the same percentage. So in India, we can say the prevalence of DR is around 16% among the diabetic patients. If we see it for overall population, this prevalence is around 1.63%, 1.63 of DR among entire population. And in subgroup analysis, what it was observed that previously the prevalence of DR was much lower in rural population, but now it is coming closer. The gap is narrowing. It was 14% in rural population, 17.44% in urban population. South India it is higher, West India it is slightly lower, and of course what is being observed that prevalence of DR was higher in the 1990 to 2000 time compared to the current time. If we include all these studies, the major risk factors for diabetic retinopathy are duration of diabetes. Higher the duration, higher is the chances of having DR. Poor control of diabetes, pregnancy, hypertension, nephropathy, hyperlipidemia, smoking, cataract surgery, obesity, anemia. In fact, obesity has been considered the most important risk factor for diabetes in our country. And this is showing the duration of diabetes and having chances of developing DR, you can see is much more with the duration of diabetes. The modifiable risk factor for DR are uncontrolled glucose, blood pressure, blood lipids, body mass index, and smokings. Some of our experience related to, the number is so high, probably we need screening for DR at community level, and for that AI is essential. So we have our primary eye care program, we have our vision centers in RP center, and currently we are doing AI-based screening for diabetic retinopathy, and that includes on an average we conduct one camp daily for DR. So nearly on an average 16 patients of diabetic patients are screened every day. And we are using this, there's no personal interest, but Remedios fundus camera. And the advantage is that we don't require online, it is even it is offline, the photo can be taken and uploaded, and it is easy to use. In last 1 year, we have screened more than 3,000 diabetic patients. There are specific referral criteria as for patients, as grade M1, R2, and R3 cases are being referred. And in fact, recently I've developed with a common screening protocol for DR as well as glaucoma in our community-based programs. And I'm very happy to share that the clinicians at RP Center, they're part of the programs, and all the patients being referred from the vision centers are taken due care at RP Center. Last but not least, the WHO India recently started a program for screening of DR in NCD clinics in India. And happy that RP Center is part of this program. And here in this program, we are involving nursing officers in NCD clinic and ophthalmic technicians who are available at community health centers. We have already trained teams in Rajasthan, Chhattisgarh, and Odisha. The purpose is that instead of going to the ophthalmic level, it should be part of the health system in the country, and we will be screening patients in NCD clinic and referring them to higher levels, either in the medical college or if the facilities for treatment available at district hospital, then in those centers. And this program is completed in 3 states. In fact, WHO themselves is implementing with various states, and RP Center is involved as a major training centers for the nurses and ophthalmic technicians. Thank you very much. Thank you.
Also, I'm glad that WHO CRO based out of Delhi is right now formulating a second edition of diabetic screening in Southeast Asia, just not India, but I've also included hypertension because 50% or more number of people have hypertension along with diabetes. But what WHO is also doing, CRO is doing, is just not the problem statement that we most probably we know, but also solution of the problem confined to the country. Example, India is a part of WHO CRO, so also Timor-Leste in East Indonesia. The two different geographic, do different GDP, do different manpower resources. So based on the available infrastructure, manpower, we are doing that. So I think we have formulated the entire guideline, most of the guideline, but it should be finalized maybe another couple of months. So that will help us for entire Southeast Asia to tackle WHO, tackle diabetes, hypertension, hyperlipidemia, etc. Yeah. Thank you.
Now invite Dr. Santosh Kopi Krishna for his talk on new insights into DME and DR management via biomarkers.
Good morning all. I thank the chair and Dr. Pish for this opportunity again. So it's a little dry topic. I'll try to keep it crisp and try to make sense of it, whatever I can understand. So I'll be talking about newer insight into DME and DR biomarkers, management through biomarkers. So one second. So when we come to the definition of a biomarker, it should be measurable. It should be predictive of outcome, and it should aid in prognosis of the therapeutic response. So it should be a valuable tool in detecting the earlier stages of the disease, tracking progression. So, but if you look at the data, the demand from the biomarkers have changed really from, it has to be prognostic and meaningful, and whereas it should be effective surrogate of management as well. So DR is a very complex pathophysiology, as we all know, including oxidative stress and blood-retinal barrier and neovascularization. So when you look at DME and PDR, these are two complete different pictures. Inflammation is more in DME, whereas angiogenic factors are more in PDR. So if you look at a normal non-diabetic retina here through the Muller cells, throughout the substance of the retina, and when you compare it to the diabetic retina, so there's lots going on. I mean, there is immune cell activation, there is gliosis, there is endothelial cell damage, there is vascular basement damage, and including neurovascular coupling changes also. So all this contribute to diabetic retinopathy and diabetic macular edema, which can be irreversible, and it can be really difficult for the vision to improve at times. And when you talk about inflammatory biomarkers, we also need to see the angiogenic activators and inhibitors, which maintain a clear balance, which is extremely essential for the healthy functioning of the retina and vision. So these are the healthy conditions, and in diabetic retinopathy, you can see the rise in these cytokines and chemokines and adhesion molecules, and this in turn increase the inflammation and retinal cell apoptosis and neovascularization. These are the known systemic biomarkers for diabetic retinopathy. And these are the ocular biomarkers that are known for diabetic retinopathy, including CRP, TNF. These are the initial biomarkers, TNF and interleukins, and then comes VEGF and PEDF. So this is how cytokines are mediated. These are meta-analysis of different papers that have been published over a period of time. You can see lots of work have been done on VEGF and all these interleukins. And even if you look at targeting inflammation also, corticosteroids, as we know, are the mainstay, the Oracort and even the dexamethasone. But even liftigras and other things are also being tried, and there are different levels of clinical trials. So many articles have been published over a period of time which show that IL-6, VEGF, and these are implicated in these conditions. There are articles which even talk about we should look beyond VEGF in the causation of this problem and progression of this problem. Even adhesion molecules also are extremely important. And there are studies which have shown that different types of macular edema have different types of in these cytokine biomarkers. And even there were studies which showed that IL-1 RA was increased in these macular edema biomarkers. So even ICAM, there is a gene polymorphism which says that when ICAM is increased, they are also prone for more diabetic retinopathy and DME. And even these soluble factors, the CD4 also is raised, especially when the patients have activated microglia and HRDs. So these are again different papers suggesting what happens in a vein occlusion, what happens in DME, and when you see a flare in aqueous also, these biomarkers are also raised. So these are the known molecular signatures, but we have only few available agents that can be injected safely, though lots is going on and research and all. So these are the newer treatment options. If you look at the newer treatment options, they are going beyond VEGF. It's targeting the basic pathology, like including the basic inflammation and even the inflammation cascade and all. By the time it comes out, there might be time. So if you look at our biomarker research at Narayan Nethralaya, this is how we go about. We have the way of doing the aqueous and vitreous humor sampling, even the serum and the tears as well. Then we store it -80. Then we do the ELISA testing and we have this. So these were the initial tests wherein we found there was a good correlation between aqueous and vitreous, so that we can easily say that, okay, we can use aqueous also to determine these biomarkers. So this is how it goes. You can do a molecular profiling initially through aqueous or vitreous humor, and you can see the severity of DR, types of DME and the treatment outcomes. Then you can go in and see the vitreous biomarkers and what happens in control cell versus PDR. In vitro models, like you can have Hubeck cells and RPE cell line, and you can inject these biomarkers and you can have the anti-agents and you can see the response, and even the mouse and animal models. So these are different results of what we found in different patterns. This is very clear cut to show that these are increased in PDR cases. Then again, in aqueous vitreous samples, the changes there. ICAM is one story what our lab is really interested in, because the cell adhesion molecules, it changes the endothelial dysfunction, and it is really associated with PDR, and especially in poor response of macular edema. So if you look at RPE cell line, you can see the difference between normoglycemic and hypoglycemic. You can clearly see that the ICAM is increased in hypoglycemic states, and when you kind of subject these RPE cells to the TNF, you can see the rise in ICAM as well as IL-6, and this rise is still persisting even beyond 24 hours. And if you look at these biomarkers, I mean the cytokines, when you inject on RPE cell line, and if you kind of see the second graph here, so when you subject it to TNF, the VEGF is not increasing, but the ICAM is increasing here. So it clearly shows that there are other molecules beyond VEGF we need to really look at, and these are the few studies that we have published so far. These are molecular proteins which are increased in diabetic retinopathy. This is beta A1 crystalline, which is high. I mean, this is a protective factor, but when you kind of cut off these factors in mice, you can see the increase in the inflammation and all. So this shows that this is a different pathway where that also can be targeted in diabetic retinopathy. Decorin levels, it's a small leucine-rich proteoglycan, and these are elevated in severe groups of severe forms of DR. And this is another paper wherein we had seen the STING pathway, and when you kind of subject these things in a mouse model, you can see that when the STING pathway is kind of aggravated, you can see a drop in pericytes, and you can see the changes in the vascular curvature also, and there are inflammatory cells that happen in the mouse model. Then again, this is another paper that talks about multiple gene products, miRNA, which has a role in glycolysis and angiogenesis. So this also can be a potential target. So if you see here, if that is kind of induced under hypoglycemic state, there is an increase in inflammation and increase in VEGF as well. So this is the biomarker pathfinder, which is a portable machine that we can measure 8 biomarkers, which is indigenously developed in NN. So this is how it goes, and we take these samples, and it's an immediate readout that you get once you place it in the machine. So we have tried to see, these are the new things that are going on. We have tried to see these biomarker, what really happens when you kind of subject AI to these. These biomarkers are taken initially, and there's a training phase where you take few controls and naive DMEs. And then again you have a testing phase when you get these suspect eyes. Then again these are the patients who have diabetes but without no clinical DR. These are all the cases wherein aqueous is taken during cataract surgery. And further, lastly, finally, we validate with eyes which have DME with a DR and without DME. So this is how it goes. So you can see the AI prediction that control is good over here, but DME again there is a change in this thing. But what we had seen is the biomarkers that were raised by ICAM and MMP9, see these are the cutoff values. So when we had seen a cutoff of VEGF and MMP9 and ICAM, so we labeled these as vascular disease suspects. These are the suspects wherein they didn't have a diabetic retinopathy. There was a chance of developing a diabetic retinopathy and diabetic macular edema later. So then we subjected it to further validation. There was a risk group, and then again we classified this as risk group, and finally we went ahead and checked these with the earlier predicted models which already had high increased biomarkers in a DR and DME patients. So this is a retrospective analysis. So what we found is these risk eyes, almost 16% progressed to diabetic retinopathy when they didn't have a diabetic retinopathy. Out of those 16%, we could see this 68% progress to severe forms of diabetic retinopathy, whereas 31% progress to DR with the DME. So when you look at these biomarkers, even before DR sets in, maybe during a cataract surgery, that can give an indication what is the chance of developing a DME or a DR. So this is AI-based stratification. So this is a vast study wherein Dr. Chaitra had presented recently. We kind of correlated these biomarkers across aqueous, vitreous, serum, and tears. I'm just finishing last few slides. This is a cluster map. So we found that there was a good correlation between vitreous and aqueous. And when you compare these four, the correlation was 28%. So coming to the conclusions, we need to look beyond VEGF to treat these patients, but obviously R&D and the time these drug comes out, it's quite some time. So these are the known biomarkers which can cause increase in severity, poor response to treatment, and this is basically a complex interplay of soluble factors. So this can be maybe considered in the future. So this is ideal biomarker, which is one which disease comes through and where an intervention kind of alters the disease as well. Thank you so much for your kind attention.
Thank you. This is wonderful and a lot of new insightful work. Since both President and Secretary of AIOS are here in this meeting, I want to ask one question that patients normally ask, that how many injections I need for my control of diabetic macular edema. I'm going to mark the question, my control. Don't give me evidences from randomized control trial done outside the country. So I suggest that VRI should take large data and don't have to do anything different, but supposing you pool the data of let's say 100,000 patients from India, different parts of the country, the way we have treated it, I'm sure that 300-400 will fit into a model which can possibly clinically say, not before doing aqueous or vitreous or anything invasive test, that yes, you might require this and that number of injections plus minus 2 standard deviation. A very important question patient asks, unfortunately not able to answer, and only quote what been published by ABC clinical trials.
Thank you.
Thank you very much. We move on to the next speaker, which is Professor Kim, who's the head of retina at Arvind. He's the president of the Vitreoretina Society of India, and they've been doing a lot of work on telescreening. So, sir will be speaking on how diabetic retinopathy telescreening has improved timely management.
Thank you, Piyush, for inviting me for this National Symposium. Telescreening has become, especially for diabetic retinopathy, it has become a very important factor. Why? As you can see, the prevalence of diabetes, I think Dr. Praveen showed excellent data. So we know the number is increasing and we are going to be facing a lot of problems related to diabetes, that is diabetic complications. With a huge number of diabetic retinopathy out there, it's the onus is on us as ophthalmologists to ensure we prevent this as much as possible because of the cost, economic cost, and not only that, the quality of life that will be lost because of diabetic retinopathy. So there's a huge economic impact due to vision loss. 47,200 crores annually is a huge number. So what should be done? Screening for diabetic retinopathy should not be limited to ophthalmologists alone. Find alternative resources like screening by physicians, screening in the community using technology. And more importantly, improve the primary care for diabetes. I know it's not in our hands, but it's something that we need to address it when you have patients who are presenting to you with diabetes but no retinopathy, early retinopathy, or whatever stage. So that is important. From VRSI and AIOS jointly published this paper on screening guidelines for diabetic retinopathy earlier, because the benefits of screening is it increases the access, improves compliance, because patients find it easier when it is done at their doorstep, cost saving, and earlier detection prevents unwanted complications. Traditionally, the diabetic retinopathy screening, we have been doing this almost 20 years now, putting fundus cameras in diabetic clinics, asking them, their technician to take a photo, send it to us, to one of our retina specialists or a trained grader would grade these images and send a report back with about an hour or two, or even overnight in some situations. So with the advent of using AI, today that's become much easier. You don't need to depend on the ophthalmologist for grading. The data is right out. Within a minute you are able to get the data or the grading, and then this can be. So we've been doing this grading for quite some time, and with the use of AI, the dependency on ophthalmologists is completely gone. What's important is it is available 24/7, and then the grading is consistent, and it does not depend on the grader or the retina specialist. So the ophthalmologist the diabetologist or the physician is happy because he's going to get the report immediately. We have done multiple validation studies using these AI, and it shows that it is almost better or even comparable to the retina specialist. So we have what we call as primary eye care centers. Many are saying these are trained ophthalmic technicians who examine the patients just like how the ophthalmologist would do, enter the data in an electronic medical record, connect to the ophthalmologist at the base hospital through video conferencing, and they would consult with every patient with the doctor at the base hospital. So we also added a fundus camera in these vision centers to take fundus photos of these patients. So what happened after we deployed AI in these vision centers or the primary eye care centers, we found before and after, the number of diabetic retinopathy identified went up by almost 8 times. So we put it again in not only in our vision centers, but we also did it in our diabetology clinics wherever we had the fundus cameras. In the last 5-6 years, we have screened million eyes. But what is important to see is the number of any diabetic retinopathy that was identified as 23.56% in the diabetic clinics versus only 9.97, which is just a simple ophthalmic clinic where all kinds of patients are seen. So definitely the diabetic clinics, you're screening the target population, that is the diabetic patients, and they are the ones who have to be screened. It is not, ophthalmologists do not get all the diabetologists, whereas medical labs, even pharmacies, and of course the physician clinics or diabetology clinics, endocrinologist clinics are the ones where you get these patients. But if you look at the compliance to referral, patients are reluctant to follow up as long as their vision is absolutely fine, they hardly go. The compliance to referrals in between these two scenarios in diabetic clinics, because the diabetologist tells go see an ophthalmologist if they have a problem, even among those who are referred, only 22% refer in the vision centers or in our primary eye care clinics, it is 70%. 70% is mainly because not just the patient takes up, the technician takes the ownership of ensuring that the patient gets to go see the retina specialist once they are referred. So that's the reason we have 70%, because they follow up on these patients, call them. You ask the physicians to do, they do not have. So how do we improve counseling for follow-up, improve awareness among all stakeholders? So the onus of screening should be with the physicians and not only with the ophthalmologist today, because as it enables screening without the ophthalmologist dependency, how do we ensure? So at VRSI, we have been working with the RSSDI, the largest diabetologist association in India, to take up this. And last year we published this paper on DR screening guidelines for physicians. And today they are also taking it up in a big way. Hopefully, we will see more physicians trying to get into this DR screening. If you look at the data from the West, in the last 10 years, there's been a decline in the vision-threatening retinopathy, unlike in our country where we are only increasing. This reduction is mainly because of improved diabetes management at the primary care level, early detection through regular screenings and advancements in treatment options. So it is important. We know if identified early, we can prevent. Even if a patient who comes to you who's a diabetic with no DR, how often do we counsel them? Very little. How often we tell them the importance of screening, controlling their blood sugar. We don't do anything until the patient develops some retinopathy. So the onus is on the ophthalmologist to ensure their diabetic patients do not lose the vision. They have to talk to their physician colleagues to take up this because it's a big value addition for their diabetic patients in the diabetology clinic if they can identify diabetic retinopathy early on. So telescreening increases screening rates, the patient satisfaction is more because it is done at one step. They do not have to walk to the ophthalmologist's office, especially when their vision is normal. So primary care integration of this DR screening will be the best going forward, and AI-enhanced screening, as we have seen, definitely will provide access to everybody. So strengthening primary diabetes care and preventing diabetes is very important. Like Singapore, where they have deployed completely, there is a fight against diabetes. Is that something we should do? Of course, not as just ophthalmologist, as a physician, every one of us should ensure that diabetes is controlled or prevented at all steps. Thank you.
Thank you very much, Professor, for this lucid presentation and sharing the data of what is actually being done at ground level at AEH. Another thing that I would like to add is it's really picking up in a bigger way, the CNN being convoluted neural networking and deep learning, and the amount of comparisons that are being done with manual graders and the accuracy with which AI is able to predict and grade is really marvelous, and it's really going to change how we really diagnose and treat these patients.
Thank you.
Thank you, Professor.
In this meeting, in different hall, talking about answering a question, is India ready to handle the retinal problems? My analysis said that blindness because of retina is 13 times higher than national average, and visual impairment 3.5x more. So unfortunately, retina is a higher problem because some diseases are even uncurable. We do not have a solution. Example, retinitis pigmentosa, we don't have a cure for that. But more importantly, also do not require a lot of higher manpower and skill power. With currently around 1,600 retinal specialists registered in the VRSI, I suggested that supposing particularly diabetes, or 101 million diabetic diagnosed, 136 million undiagnosed diabetes, if you divide that into the general physician, with 1 million plus people in India, then it actually requires not more than 2 patients to be screened in a day. In a 242 working days, I didn't take 365 because you need vacation, Sunday, etc. And similarly, if the general ophthalmology have 28,000 plus now, they require only less than 3 patients to treat a day. Supposing we democratize our screening to the general ophthalmologist, general physicians, and democratize our treatment, particularly because most of injections today, injection can be given to anybody. If they go intracameral, can also give intravitreal. To general ophthalmologists, most probably will burden reduce. But in addition, if you use the AI, they don't have to refer to a physician, refer to an ophthalmologist or something like that. I think when we think little differently, most probably like UK, Singapore, etc. have done, we can also handle this problem for future. Believe me, from the public health perspective, DR in India is not a problem. ROP in India is not a problem. We only because retina statistics keep on talking. Still refractive error cataract are a problem. But this will become a problem by 2030, 2035. Do not take care from today. So thank you, Kim, for giving the insight. You are doing wonderful work. So keep this in mind, that how do we all together encourage general ophthalmologists to also to treat and physician to also to screen. Thank you.
Yeah. Next call upon Dr. Manisha Agarwal for a talk on imaging in diagnosis and management of diabetic retinopathy.
Dr. Manisha Agarwal is currently the General Secretary of the Vitreoretina Society of India.
Good morning, everyone, and thank you, Dr. Piyush and Dr. Taraprasad Dasa, for making me a part of this wonderful National Symposium on Diabetic Retinopathy. So, imaging modalities in DR are of significant utility not only in the management but also in the screening, evaluation, and diagnosing diabetic retinopathy. There are various imaging techniques that can be useful depending upon the manifestation of DR that you are dealing with. It could be right from a simple color fundus photograph to more complicated investigations like fundus fluorescein angiography, OCT, and OCTA. A simple color fundus photograph is extremely important when you want to screen a patient for diabetic retinopathy, and it's also important to do a documentation of what stage of DR you are dealing with so that you can properly counsel the patient for further management. It is also useful for monitoring the progression of DR, and there are various types of fundus photographs which are available in today's time. Fundus photograph again can be very useful, and it can be used for screening patients in non-ophthalmic clinics using either a non-mydriatic fundus camera, which are AI based, or by using telemedicine, as was very beautifully shown by Dr. Kim. The advantages being that it has an easier access, better compliance, as these screenings can be done at primary healthcare provider clinics themselves without really having the patient to specially come to ophthalmic clinics for just the purpose of screening for DR. If you use a telemedicine unit or a model, then the turnaround time is about 1 hour. And if we are using an AI-based non-mydriatic fundus camera, then the turnaround time is as short as 1 minute. Coming to fundus fluorescein angiography, we have to remember it's an invasive procedure, so it cannot be taken lightly. However, it still remains the gold standard for management of DR. There are various indications for performing an invasive procedure like FFA, which does have a potential risk of various complications. So we have to know when to really indicate a patient to undergo an FFA. But the importance is that in today's time, we have wide field angiograms, and they are revealing much more information about the peripheral changes of DR rather than the typical ETDRS field that we were using initially. A wide field FFA can also play a very important role in planning the management, and when you have patients with persistent neovascularization of the retina and you do a wide field FFA, you are actually able to identify the peripheral areas of the retina which require more laser photocoagulation because of the persistence of the capillary non-perfusion areas, leading to the persistence of neovascularization of the retina. Coming to OCT, we know it's a non-invasive test. It does a quantitative assessment of DME, and there are various types of DMEs which have been described. We can also monitor the response to treatment, and also the recurrence of edema can be very well identified. We are also talking of various OCT biomarkers for DME, and these are very helpful when we are planning the management, such as in the first case, you see a thick epiretinal membrane which requires a surgical management and is going to actually deteriorate if we try to give anti-VEGF injections in such a patient. A patient with neurosensory detachment is an indication that this patient is going to respond better to steroids rather than anti-VEGFs. And then the patients who are having degenerative changes like drill and roll are the ones who are not really going to visually benefit on continuing treatment with anti-VEGFs. Coming to OCTA is a non-invasive tool, and it is used both for qualitative and quantitative assessment of macula, including ischemia. There are various angiographic features which you can very well pick up on an OCTA. The various OCTA metrics used for a DR patient are the vessel density, the FAS area, and the area of non-perfusion, and they all help to monitor the progression of diabetic retinopathy. There are various features, again, like you have the microaneurysms, which can be found at various layers on doing an OCTA. though still we know that FFA is going to be far better in picking up the microaneurysms. You can also pick up other features like an IRMA, the hard exudates. They can all be very well appreciated on doing an OCTA. OCTA can also image the neovascularization of the retina very nicely. And if anybody wants to really know what is going to be the advantage or disadvantage of doing an OCTA over an FFA, well, the advantage is you can pick up very subtle NVEs. The precise measurement and monitoring of the size of NVE is possible, which is obscured due to the leakage on FFA. However, the disadvantage is that the focus depth range of OCTs limits the visualization of highly elevated NVEs beyond the margin of the ILM, which may appear as a shadow rather than the flow. A manual identification of NVE may be more significant. Now, this is a photograph, a color fundus photograph, where you find that you are having these multiple NVs of the retina, and these are very beautifully appreciated on doing an OCTA, adjacent to the CNP areas, again detected on an OCTA. However, if you compare OCTA with an FFA, the disadvantage is that you're not really finding the leakage, the active leakage, which is very well identified on the FFA in comparison to an OCTA. So the monitoring the regression of the neovascularization again can be very well monitored by doing OCTA. And here you have an OCTA picture where you have a very active frond which has regressed on doing a laser photocoagulation. And again, the same can be appreciated on doing an FFA, which shows a florid leakage and shows minimal leakage after the laser photocoagulation. Again, the NVE, which shows a flow when it is active and which has beautifully regressed on doing laser photocoagulation. Macular ischemia again can be picked up by the enlargement of the FAZ, and this again can help you to grade the kind of DR that you are dealing with. The importance of OCTA is also in the recognition of subclinical DR, which has not been possible with any other imaging modality, and changes such as a decrease in the deep plexus vessel density, enlargement of the FAZ, decrease in the parafoveal vessel density both in superficial and deep vascular layers, and impairment of the choriocapillaris can actually detect a subclinical DR even before our eyes can pick up the changes of DR on clinical examination. We now also have a wide field OCTA, which is going to be very useful in picking up these changes in the peripheral retina. Coming to future in diagnosis of DR, the integration of ultra-wide field color fundus photography, OCTA, the omic and the other biomarker research, the artificial intelligence and statistical modeling, they all together are likely to facilitate new DR classifications even before we have clinically manifesting signs of DR on clinical examination. And this is going to help in personalized care for DR management. Therefore, to conclude, color fundus photograph helps in screening for DR even outside the ophthalmic clinics using teleophthalmology and AI-based cameras. Multimodal imaging, including FFA, OCT, and OCTA, help in evaluation, prognostication, and management of DR. Wide field imaging may help in identifying the peripheral retinal changes and early diagnosis of DR. And OCTA may be very helpful to pick up subclinical DR, which has not been possible till today. So thank you so much for patient listening.
Thank you, Manisha. The new idea is emerging in this country is can you self-image your retina and then decide when to go or not to go to a physician or ophthalmologist. The idea comes from your clinical thermometer. Now you measure your temperature, you say up to 99, I will tolerate, up to 99.6, I will take a dolo, crosses 100, I'll go to a doctor, etc., etc. So that is not yet completely ready because it requires one imaging system which can diagnose an undilated people properly. It currently available anywhere in the world, including India, is not 30% failure. And then the two should be cheap enough to buy.
Right.
Just like buy a glucometer at home, you can measure your own diabetes, own blood pressure. So this is actually good idea. I will encourage that idea. So suppose you all encourage our companies to make the phone or camera smart enough, cheap enough to take a photograph, and then do an AI on that, diagnose in a traffic color of a green, don't go yellow, think about going yellow, red, definitely go. Most of all, this will also another way of solving our problem, because the Indian diabetic population is more than the entire UK population. Think about it, what problem we have got. Thank you, Manisha.
Thank you, sir.
Can I call upon Komal Agarwal from Lucknow, talking about is earlier vitrectomy better in vision threatening PDR? Very, very important question and dilemma for all of us.
Good morning, everyone, and I am here to fill in for Dr. Shobhit Chawla, who could not be here. And the topic that I am talking of today is earlier vitrectomy better in vision-threatening PDR? We know for PDR, the treatment options in our armamentarium are the entire gamut of anti-VEGF injections, laser photocoagulations, and also vitrectomy, all of which have their specific indications with specific advantages and disadvantages. When we talk of anti-VEGFs in PDR, they have shown promising results in decreasing the progression of PDR to tractional detachment. More importantly, it decreases vascularity and aids in the future treatments, but also is a smaller procedure, very easy to do. But it comes with its own disadvantages, like a limited duration of action, has a crunch effect on very vascular PDRs. We cannot underestimate the cost burden that it puts with the burden of multiple visits and travel, and is also unreliable in a good amount of patients who are lost to follow-up, which cannot be underestimated, especially in diabetics. So if you look at the protocol S data at 5 years, we see that 14% of these patients required PRP, 48% developed VH, 3% developed a neovascular glaucoma. But more importantly, a lot of patients showed progression to tractional detachment, which 19% of which required vitrectomy. We move to the laser photocoagulation in PDR, which has been the standard of care and kills the hypoxic areas and is also cost effective. But it can be limited by the vitreous opacities like cataract or vitreous hemorrhage, which are not uncommon in PDR patients. Anterior retina may remain untreated, which may lead to a neovascular glaucoma. PRP can also increase traction in a certain subset of patients of PDR. Again, when we look at the protocol S data, at 5 years, 45% of patients who had already undergone PRP required an additional sitting of PRP. 46% developed VH, and 14% required vitrectomy. Another study by Khan et al., which showed that at 10 years, 89% of patients required additional PRP, and a good amount of 33% required vitrectomy. So till now, the traditional indications of vitrectomy have been huge, but the most common indications being a non-resolving vitreous hemorrhage and a tractional detachment, which involves or threatens the macula. Early proliferative diabetic retinopathy with or without pre-retinal hemorrhage comes very lower down the list. If you look at this patient, a patient of ours, 43-year-old female, presented to us with 660 vision. On the OCT showed minor traction at the macula. It was getting detached. Some amount of subretinal fluid was also there. He was already lasered with some skip areas. Now, at this point of time, the patient was not ready for a vitrectomy. However, we convinced him. We tried to convince him, but he did not. 3 months later, he came to us with 460 vision, increase in traction, increase in the fibrovascular proliferation, and increase in the detachment at the macula, and ultimately had to undergo a vitrectomy. In comparison, this was a 62-year-old female with a 6/9 vision, very stable. But if we look closer, along with the fibrovascular proliferation, had a small amount of SRF which was peeping. It was still not coming to the macula, hence explaining the good vision. This patient we took up for a vitrectomy at this stage, and even 1 year later, she was absolutely fine with a maintained BCVA of 6/9. So why are we talking of early vitrectomy? we have seen that long-term follow-up of vitrectomized eyes in diabetic retinopathy versus the non-vitrectomized eye show that there are lower rates of additional treatments, lower rates of progression, better best corrected visual acuities with a stabilized anatomical and functional outcomes. So is it that we should consider early vitrectomy in all cases? Well, not really. The thing that we have to look for is the vitreous status. And we all as vitreoretinal surgeons know that vitreous scaffold is our enemy in diabetic retinopathy cases. A large study by Ono et al. Saw 400 patients where they compared or assessed the proliferative diabetic retinopathy with the posterior vitreous detachment. And they saw that in patients who had complete PVD, 0% of them progressed to a tractional detachment, whereas 100% of the eyes which had partial PVD progressed to either vitreous hemorrhage or a tractional detachment. About 44% of eyes progressed to a to tractional detachment where there was no PVD. So the role of vitreous cannot be underestimated. In cases where there is a complete PVD, new vessels can only grow on the retinal surface. There is no vitreous traction for bleed or a tractional detachment, and hence, when treated with laser, can have a sustained stability. Essentially, vitrectomy does the same thing. Vitrectomy removes the vitreous scaffold, which is responsible for progression, and hence, early vitrectomy can help in these patients. So the goals of vitrectomy are clear. First, we remove the vitreous opacities and remove the fibrovascular membranes which are causing traction. It is important to remove the posterior hyaloid and all the second or the double membranes, which was very nicely shown by Dr. Dave. We release the tangential and the anteroposterior traction and control all the bleeders to attain a good surgical outcome. So if vitrectomy is so nice, what has stopped us from doing an early vitrectomy till now? So till very recently, the vitrectomy systems did not allow us to have good surgical outcomes. The incidence of the iatrogenic breaks were high, and the anatomical failure ranged from 7 to 22%. There were cases which experienced visual acuity loss post-vitrectomy and ranged till about 34%. But it's also important for us to know that this is the data where the patients were operated on advanced PDR or tractional detachment with poor retinal perfusion and poor systemic control. So what has changed? Now we have smaller gauge of instrumentation, we have better fluid dynamics in our vitrectomy machines, high cutting speeds, and good pressure controls. We have anti-VEGF agents for pre-op control and wide-angle visualization or 3D visualization, which can lead to better surgical outcomes. We look at the cost effectiveness and we find that the total cost of burden of vitrectomy is comparable. When we do an early vitrectomy, there's long-term stabilization with lower rates of repeat procedures, whereas in other treatments, there are additional treatments which will be required over the years. The progression is common, and hence they might need vitrectomy anyways in future. We cannot underestimate the cost of travel, visit, and work loss. So to conclude, our focus should be on better functional outcomes rather than only attaining anatomical outcomes. We see a shift in vitrectomy systems. We have better instrumentations now. We should always consider the vitreous status and the systemic status. In today's world, it is important that we should evolve rather than just adhere to the old paradigms. Thank you.
Thank you, Dr. Komal. I think you've covered most of the things. Another point in this regard for early vitrectomy would be, in my particular case, what happens is these patients are going to have a tendency to develop macular edema. So if you can avoid a vitrectomy in those situations, then in that situation, but anyways, we have to wind up the session. So we'll move on to the next talk, which is by Professor Ajit Babu Maji on pearls of surgical management of diabetic retinopathy. Dr. Ajit Babu Maji is the past president of AIOS as well as VRSI.
Yeah, Thank you, Dr. Das and Piyush, and I would like to thank at the outset both AIOS and VRSI for giving this opportunity in presenting in National Symposium. I was asked to speak about pearls of surgical management of diabetic retinopathy. If you see my slide, first slide is a proliferative diabetic retinopathy. Not so much an indication for vitrectomy in diabetic retinopathy. But why I have put it is, immediately after the laser, this patient has developed a combined reg plus tractional detachment. That means there is always a danger that lurks around while you are taking up a patient for panretinal photocoagulation in a proliferative diabetic retinopathy by a general ophthalmologist. So technology has helped us in vitrectomy to revive this patient. But what has happened is a meticulous laser was not done. If the meticulous laser is planned, this complication would not have happened. So prevention is always better than cure in certain cases of proliferative diabetic retinopathy with membrane proliferation while you are taking up for panretinal photocoagulation. This is a preventive measure. Komal has shown several cases of tractional detachment with proliferation where there is laser but seemingly stable retina. But these cases do require early surgical intervention to stabilize the retinal status so that both functional and anatomical stability for a longer run will be achieved after ars plana vitrectomy. So this is also essential. If you see the vision in this patient, it has dropped down by one line, but this vision will remain for next 1 decade or so, rather than if you don't intervene, it will reduce much faster. This is a software engineer with bilateral proliferative diabetic retinopathy with proliferations in both the eyes, amounting for almost like indication for a vitrectomy. If you see the outcome, this is good outcome, 20/30 vision. So again, as I told in the previous scenario, where intervention has resulted in less vision and a stable status, here better vision and a stable status. Both can result with early interventions in proliferative diabetic retinopathy with tractional retinal detachment. This was briefly talked by Dr. Vivek Dave, that subhyaloid hemorrhage in proliferative diabetic retinopathy. Though I thought he will mention about the matter of fact that subhyaloid hemorrhage clinically, when it is in young, it happens, we treat it by egg hyaloidotomy to release it because it is a non-surgical procedure. However, in diabetics, the posterior hyaloid is very thick and it is very resistant to egg hyaloidotomy. So these cases, you should go ahead with a vitrectomy. There, not only we remove the posterior vitreous scaffold, the primary pathology here is the proliferation, vascular proliferation. That also will be tackled, means that will be removed, and a panretinal photocoagulation during endolaser during the surgery will help us stabilize the retinal status. This is the outcome, 20/30 vision from counting fingers, 2 meters. And Komal has briefly touched upon the anti-VEGF use, but this I should want to limit for preoperative rather than a regular proliferative diabetic retinopathies. Yesterday in our instruction course, we clearly demonstrated a repeated anti-VEGF injection without surgical interventions has enhanced the fibrous proliferation and the tractional detachment has worsened. However, pre-surgical preparation, if there is a vasoproliferation and a fibrous tissue, the vascularity will come down and the dissection will be relatively blood-free, and the dissection can be more complete. So that can be used in cases which are moderate to severe proliferative diabetic retinopathies going for surgery. This patient, this is the first post-op day. You can see it is relatively bloodless. To give that picture, you need to have a relative avascularity in a vasoproliferative process. And when there is severe fibrosis, though Komal, I think Vivek mentioned the proliferation of the posterior hyaloid, the field gets affected. These patients, his vision is 20/60, but if you do the field, severely gets affected. So when you are intervening, his vision improved by one line, but the field will improve manifold. This is from a South Africa patient who is a businessman. While coming into my clinic, he was fumbling to come. And post-operatively, he is free and he started his business again. That's what it does in relieving the fields. Then vitreous traction with recurrent hemorrhages. It's a very simple happening. This patient got 10 times PRP. The patient recurrently bleeding, and the treating doctor has not identified there is a vitreous traction. You relieve it. It is a simple vitrectomy. Not very complex, but relieve it once for all, it addresses the patient's trouble. This I purposefully kept. This is not even for routine general ophthalmologist. It's not even for early vitreoretinal surgeons. It is for very experienced surgeons, because I see so many patients, doctor, you do whatever you like, because they already heard at several places that nothing can be done, please leave it alone. So these cases, we need to go after them, because we cannot leave them blind. So I have taken their worst eye, right eye, and we relieved it. They got 2 meters. They are happy. And the second eye, though it is very severe, better than the right eye, so got 2200. I am the happiest. Always vitrectomy do not mean that it gets relieved and good results. No. These patients, especially I have seen this fibrosis, I don't know about TPD, he may address it. If this sugar perioperative period it's not under good controls, there is aggression of fibrosis where you relieve all the membranes, again membranes recur and the traction worsens. This is what has happened in this patient. And post-operatively, luckily, we removed all the membranes and he gained the vision. And the patient's other eye, because of the fibrosis, the break has really become very large because of the fibrosis only. And I had to do cryo and a lot of membrane dissection and to stabilize it with difficulty. So judicious laser is very, very essential. This is for the general ophthalmologist when you are taking up PDRs for laser. And simple vitrectomy is helpful in preventing recurrent PRPs in those traction, when vitreous traction is associated. PP with membrane dissection, maybe 60% of the patients you can handle very easily. Anti-VEGFs are really useful when there is a vascular proliferation along with fibrosis. Very advanced PDRs, there are no rules, no procedures, no steps. But experienced pair of hands are very much required in these cases. Thank you very much for your attention.
Okay, thank you very much for everybody, though many are not here, so we can't have a panel discussion, but question number one is that do you have any question for Ajit? I have worked with Ajit, and I can tell you very clearly that Ajit's surgery is like watching or writing a poetry. So in my system, whenever I have a difficult case, give it to Ajit. And then when patients say, please you do it a favor, I said, I'm doing a favor only by giving it to a better surgeon. So Ajit maintains a lot. But what I told about it also is that when do you say yes, when do you say no? And last slide was never say die, because even a 2-meter vision is better than hand motions. And two, that with the new technology of low vision aids, even 2-meter vision can really do wonders, actually. And but also important is to diagnose when to treat. My friends in Finland particularly, they have said that what are talking vitrectomy in diabetes, you do not do anymore, because patients are diagnosed early, treated so adequately with the laser before, and today with anti-VEGF and combination anti-VEGF and laser, the patient do not land up in vitrectomy. So someday I'm sure 30, 40, 50 years from now, we'll have enough surgeons, enough resources, enough advocacy, enough time, patient coming right time to the doctor to treat. I'm just digressing to a certain extent that I grew from a situation where I do not do cataract surgery unless patient with light perception or hand motions, white cataract, brown cataract, etc. 3-4 months ago, there's a beautiful 2 publications from Tulsi Raj group from Madurai that the threshold for the acceptance of cataract in a rural Tamil Nadu has come down from hand motion to 618, WHO says 612. So that's because there is advocacy that cataract surgery works, IOL is a good. Similarly, supposing all of us start advocating that early diagnosis and treatment is better than doing a vitrectomy or can avoid complications, that will be wonderful. Having said that, definitely at least 1-5% people have required vitrectomy 30 years from now. I want to see that less and less vitrectomy, more and more preventive care, both systemic care and also anti-VEGF and plus minus laser. Thank you, Ajit, for wonderful session. We have 16 people are counted to have gone, so 13 people now. So in case any of you, and we have got time allotted another 4 minutes, we have got by scientific committee of AIOS. Any 4 minutes want to share anything on the dais or off the dais, please come on, sir. I like it. Please.
Yeah, that's good.
If you can come to the dais, use the mic, it will be easier. And please identify so that, because you don't know everybody, that will also help us.
I have a question for Ajit sir.
Yeah,
sir,
identify yourself first.
I am Dr. Siddharth Bose from Calcutta.
Yeah.
And this is a very important question. Like you mentioned in a slide that if in spite of having extensive PRP, patient is again and repeatedly bleeding. So in that case, can I be confident in doing a vitrectomy and not end up in severe complications of vitrectomy? How confident are you in these cases?
Yeah, that line you need to draw, but what I will say, I will give you guideline there. The thing is, previously we used to teach a lot, even TP must have taught several times. The posterior hyaloid forms a scaffold and the vessels grow over the posterior hyaloid. What we are targeting with PRP is our retinal neovascularization, which is not attached to the vitreous. So if it is not attached, they will regress completely. But those vessels which are growing over the posterior hyaloid will never regress. That's why in spite of 10 laser sittings, it's not regressed, and whenever there is a moment, it bleeds because there is a free vitreous which can be mobile and lead to vitreous hemorrhage. Yes. So those cases, the expertise for vitrectomy high expertise is not required at all. If you have seen, there are no membranes actually, there is adhesion. But you need to understand, in diabetics, the vitreous adhesion also, it is different. It will be a little bit more and it will be variable. While doing some PVD induction, if you see in Vivek Dave's, it is a little bit fast. I would not do so faster PVD induction. The relatively different adhesion will be there. You need to be a little bit careful, but you should be able to do if you have a average vitrectomy skills.
Thank you, sir.
Sir, in
Yeah.
case of
Use the
non-resolving,
microphone. Use the microphone. Yeah.
so in case of non-resolving CSME, sir, what is your experience of using combination of triamcinolone with anti-VEGF?
Yeah. Non-resolving CSME, usually first, non-resolving means first systems you should eliminate. There must be so many systemic derangements must be there. Those should be investigated thoroughly and that should be controlled well. That is my first suggestion. Second, see whether there is any taut posterior hyaloid. That can be a second reason why, in spite of all the injections, the CME is recurring, and it is along with the exudates. Third is there any plaque formation or not? Because hard exudates slowly with each injection, it migrates towards the center and it may result in plaque formation. If these things are not there and the posterior hyaloid, the vitreous is not at all causing any traction, probably you can consider.
Okay.
Sir, I have one question here.
Yeah, please.
Dr. Sanu. Sir, in cases of advanced cases of PDR with tractional retinal detachments, most of the times we end up doing a combined surgery or maybe a cataract surgery later. These cases develop a PCO later. So how do you manage these cases? Because the moment we do a YAC caps, there is a communication between anterior chamber and posterior chamber and goes in for an NVA and NVG. So these are tough situations. Patients most of the times one-eyed, systemic issues. I find it very difficult to even try to do an YAC caps after S4 also. So how do you kind of manage?
The thing is, the post-operative period, if the retina is stable,
correct,
and you have done adequate laser, and certain times maybe the peripheral cryo,
right,
and it is stable for 3 months, the worsening will not happen. But these ultra advanced, I always say, means there is nothing called ultra advanced, but I use the term ultra advanced for the facility.
Correct.
There will be a peripheral elevation of the retina that is ischemic.
Correct. Yeah.
That's why the factors will be secreted and it will be in the vitreous.
Correct. Yeah.
So those will come anteriorly once a cap is done.
Yeah,
so that such elevations you give injection and then do the eye cap. So 1 to 6 weeks time, everything will stabilize and then there will not be any risk of neovascular glaucoma in these cases.
Thank you, sir.
Please.